that if you're not presenting, you should be on mute. And I don't know if, Jess, do you want to do a quick sound check? We never have problems with you.
Sure. Can you
Okay,
hear me?
there you are. Yep. And I heard from Dave Merman and Tom. You want to do a quick sound check?
Sure, how's this?
Sounds great. Good. Board member Lunge is the person we sometimes have issues with the sound, but I don't see her on yet.
Hi, Susan. Can you hear and see me? Great.
Yes, I can.
Great. Thank you.
Thank you so much for getting back to me. I'm so
Again, if you're not on mute, please mute yourselves. Thank you very much. Board member Lunge, do you want to do a quick sound check?
Sure. Thanks.
Okay, great.
Is it working? Yeah. Sorry, I was a little late.
You're fine. Okay, well, it's 1 o'clock and we have 5 board members, so I'll call to order the Green Mountain Care Board's hearing of May 31st, 2023. We have 2 agenda items. First, we'll take up VA's request for reconsideration of fiscal year 24 hospital budget guidance, and there's a potential vote noticed. And then we'll take up the vital budget and modification to the health information exchange plan, and there'll be a staff presentation and a potential vote. We had an agenda item relating to the ACO from a request that came in yesterday, but we've removed that from the agenda so board members have time to review it and consider it. And we're going to take that up on June 14th. And with that, I'll turn it to our executive director, Susan Barrett, for her report.
Thank you, Mr. Chair. Good afternoon. Reminding folks that next week, June 7th, we will be on the road. We'll be in Morrisville, Vermont, in Lamoille County. We will be conducting an in-person public board meeting at Green Mountain Services and Supports, again in Morrisville. So we are going to learn about the healthcare landscape in Lamoille County. We're also going to have a roundtable discussion to look at some of the barriers to addressing affordability, access, and quality in healthcare. And we are just really grateful to the Morrisville community for hosting us. So we will not have a call-in option for this meeting, but we will record it. And if you are local to Morrisville, or if you know folks, or Lamoille County, you know folks in that area, please send them along. More information is on our website if you are interested in attending. In terms of public comments, we don't have any open public comments currently, except for the ongoing public comment regarding the next potential model. Please send any of your comments to us. We share those with Agency of Human Services and the Governor's Office as they are leading those negotiations. And with that, I will turn it back to you, Mr. Chair.
Thank you very much. We have minutes from May 17th. And is there a motion to approve the minutes?
I'll move approval.
Is there a second?
I'll second.
Great. And all those in favor, please say aye.
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 Aye. And the vote's unanimous and the minutes are approved. And is Director Lindberg here? Mr. McCracken? Here we go.
Good afternoon.
How are you? I'll turn it over to you.
Thank you. Just trying. All right. Are you able to see my screen?
Yes.
All right. For the record, my name is Sarah Lindberg, and I am the Director of Health Systems Finance Team for the Green Mountain Care Board. I'm joined by Russ McCracken, a staff attorney who is so kind as to help us out. We're here to discuss VAS's request for reconsideration of the fiscal year 24 hospital budget guidance. So just for brief background, in March of 2023, the Green Mountain Care Board approved the hospital budget guidance for fiscal year 24. We outlined that this represented a bridge year between the way that Vermont historically has regulated hospital budgets and some new methods that we're pivoting toward. Pretty exclusively in the history of this regulation, hospitals have been judged based on their net patient revenue growth. And the Green Mountain Care Board is interested in making a change of direction to instead look at expense growth that is benchmarked to relevant indicators seen in other markets. This is, so one of the things we tried to do is suggest standing that up in fiscal year 23. We decided no one was quite ready for that. And so we decided to stick with our tried and true net patient revenue. And it turned out that that had been established in the fiscal year 23 guidance as a 2-year growth target. So that guidance was adopted in March of 2022 and said that the growth from the fiscal year 22 to fiscal year 24 budgets should be 8.6%. So we received a letter from VAS on May 3rd requesting that the Green Mountain Care Board reconsider the fiscal year 24 guidance and either utilize a growth factor that would support positive operating margins for the hospitals, or stipulate that the actual fiscal year 24 budget results would not be enforced. There are concerns cited in the letter related to hospitals' fiscal health and their ability to serve their communities if they were to follow the guidance. And it highlights some of the challenges faced by hospitals if they don't know their budget until 2 weeks before the start of their fiscal year. Just so happened this morning, Kaufman Hall released their May update. This is national information about what in the US hospital operating margins look like year to date. So April of 2023, again, cumulatively is the best hospitals have looked in over a year, and that's barely break even. Again, these are national results and they do tend to change as more data becomes available, but it's no joke that the hospital sector is in really rough shape at the moment. Some of the challenges are continuing cost pressures based on employment costs and expenses, as well as some true volatility in patient volume. More is being shifted to the outpatient setting, and it's very hard to kind of predict the tea leaves these days. There's also some speculation that some of the improving results may be early indicators of the Medicaid redeterminations that are being rolled out across the United States due to the end of the federal public health emergency. So there will be 2 essential questions here that we'll try to tackle hopefully in one vote today. But the first question is, should the fiscal year 24 benchmark for net patient service revenue growth be increased? Why might the board adjust the guidance? It would be an opportunity to incorporate more recent information that would better respond to the significant expenses that hospitals are facing, especially related to workforce and inflationary cost growth. And then hospitals, as mentioned in the VAS letter, suggest that it might provide more certainty in the budgets they're currently developing to submit before you on June 30th.
And then you then move from New York back to North Carolina. Where did you go? To New York?
Excuse me if you, yeah, thank you.
Why would you not adjust the guidance potentially? That would reduce the that would essentially eliminate the consistency and predictability that was intended by establishing a multi-year benchmark. There is not like a single number that would solve this problem for all the hospitals. And finally, there's great concern that we hear about how this might contribute to higher prices for consumers, especially those with commercial or self-funded coverage, and the idea that, you know, this additional money would have to come from somewhere and what that would mean to our system. The second question is that should the enforcement be waived if the fiscal year 24 benchmark for net patient service revenue growth is not increased? Why would you consider waiving enforcement? Well, it would mitigate some of the concern hospitals are feeling if they potentially submit a budget that is overly ambitious and difficult for them to achieve and result in some financial penalty or other harm to the hospital. But the flip side of that is it would limit the board's ability to address circumstances that may warrant enforcement. I believe that the actual fiscal year 22 results to me were evidence of good faith in that many hospitals did blow their NPR targets, but there was not any talk of enforcement. So I do believe there is precedent that the board is in recent years has not abused that provision. And I will say that to my knowledge, the only time that enforcement's ever been waived to date was related to the COVID-19 pandemic. So a pretty extreme circumstance. So public comment, we got a few. I know that it was a very engaged process. So overall, we didn't quite hit 100. There were 98 written public comments that came in. And if we had any late arrivals, we haven't accounted for, apologies. But I had read in all these 98. I believe I'm not the only one who can say that. So it was essentially a coin flip between those who were advocating to maintain the current benchmark and those that were advocating to increase it. Of those who recommended that the board stick with the benchmark, payers and employer groups submitted 2 comments, small employers 8, independent providers and their patients submitted 30 comments. The healthcare advocate submitted 1, and then there were 6 additional comments that were not directly affiliated with one of these groups. Some of the points that they made was that the expense pressures are being faced by more than hospitals. So plenty of industries are dealing with the same pressures and finding ways to make it work. They talk about the long history of premium increases for individuals, for employees, and for employers who often bear the cost when more revenue is needed. There was some reminder that this process is good, positive in their opinion, because it fosters accountability and transparency. That hospital rates are a significant driver of the premium increases that ratepayers are paying. And then there were some arguments that the reimbursement rates available to independent providers are affected by how much hospitals are paid. So those were kind of, I think, representative of the 47 comments you see there. For those who are advocating that the benchmark should be increased, 37 were affiliated with a hospital, be it as a staff member, employee, or trustee. 11 hospital community partners came on this side. The Vermont Medical Society, which is uncommon for them to make a comment in these situations, felt compelled to say something. And there were 2 public comments from VAS on the topic. These really focus on how difficult it is to constrain the expense pressures being faced by hospitals, the unprecedented inflation and other cost growth that they are grappling with, concerns about harm to their communities if the hospitals are not financially viable, feeling that they would be forced to cut services or otherwise restrict access that is needed for their communities, and just citing that without sufficient revenue, they can't continue to invest in infrastructure and keep things in good shape without that additional money and the effects that might have on the treatment of patients. So just a reminder that, over time, hospital budgets have largely been approved close to their submitted requests. So the way we had calculated this is over 99% of both total and commercial net patient revenue. Just want to flag here that it's come to my attention that our data systems aren't maybe doing the best job of measuring this. And it's going to be a highly manual process to try to get back to what was submitted and what was approved due to some rebasing of budgets. So I think that we just want to be really transparent that that's a limitation of how we've looked at this so far. We will get that right, but it will be quite an effort to try to get that right size as maybe some participants today who have been a part of this process for a long time. It's like we haven't always put in the provider transfer in the same place every year. So stuff like that is just adding some noise to this, and just but I would say it's still by and large, requests have largely been fulfilled, but I doubt that it's probably 99% is all. So when we look at historically, NPR submissions and approvals, we'll see that every year over half of the hospital requests are above guidance. To be clear, they tend to be pretty close to the guidance. So on average, for the past few fiscal years, it's been 2.8% above the guidance, the benchmark in the guidance, and the approvals were about half a percentage point lower than that at plus 2.4%. So there certainly is precedent for budgets both being submitted and approved over that guidance period, but not nearly probably the magnitude that hospitals are feeling they will have to submit for the upcoming budget. And this is just trying to give you some more detail about this. So each kind of box is a fiscal year. So you can see in this upper left-hand corner, the gray dots are what the NPR was approved versus the green dot, which was submitted, with the dash line representing the NPR benchmark for that year.
Your masters, how you get to sleep.
And so you can see that it does vary by year. So for instance, fiscal year 19 was quite a low benchmark, 2.8%, and nearly all hospitals submitted above that that target. So whereas in other years, it's been closer to half and half. So then there was a request last week to look at some of the changes by payer. And so when you think about patient revenue, you think of two numbers, or at least I do, and that is what the gross revenue looks like and what the net revenue looks like. So gross revenue, again, is kind of like your measure for resource use. It is how much, if everyone were paying the total charge, which if you ever look at an explanation of benefits, there's usually that charged amount with a negotiated discount that gets you to the actual reimbursement. So these gross amounts are not what is actually recouped, but helps you understand how much resource utilization has changed and evens it out so that you're not measuring reimbursement differences. So on that gross or overall level, you can see that Medicare utilization has changed at the most at an increase of 35%. Whereas Medicaid is not far behind at 32%, but still representing, a far lesser amount of the gross amount of services that are being produced. This is going to be not based on payment rates, because remember, we haven't gotten there yet, but this is mostly about kind of the services that population needs, which makes sense as it tends to cover a high proportion of children. And so in that same time period, the commercial has gone up the least at plus 22%. And then when we look at the net increases, so that's how much the actual net revenue has changed. Commercial has climbed by 18%, which is very close to Medicare at 19% and Medicaid at 28%. And over on the right-hand side, you can see that the discrepancy between how much of the payer mix contributes to that gross versus net picture. So here's where we see that while Medicare is 47% of that service utilization, they're 35% of the payments. And that's some of the price discrimination, cost shift kind of conversations we've been having recently, is why those gross and net numbers are further apart for some payers. I will say that when we do talk about the gross increase, we're measuring not only kind of utilization-based changes, but charge increases. And if you back out all the approved change to charges since fiscal year 13 in this time period, about 20% of that slope is change in charge. So if you take that 20% off, you kind of get to the deflated gross patient revenue. All right, I can tell I'm losing people. We'll move on. I'm sorry. So that's just the details if you want to recheck our math. So one thing that, is that this guidance has, is not necessarily new. I know there's the reconsideration has really brought it back to our attention, but I was struck by this exchange that happened in the fiscal year 23 budget hearings, where a board member said, what happens if we approve your budget as requested and we approve other budgets that exceed the guidelines? And a hospital CFO said, I believe that every hospital asks for what they need, and we always want to hit the guidance. We always want to follow the rules. Us going over 8.6% so that we could have more than 1% margin and would jump our rate increase request into double digits. We just couldn't do it, right? That's just not what we wanted to do for Vermonters and our patients and our community, for ourselves as an organization. We wanted to feel like we were going into we were going to own some of the state of healthcare in Vermont that we find ourselves in right now. It really was a budget based on need. I think everybody's is. The GMCB does not have an easy task of trying to determine that everybody's budget is based on need, but I think we would still feel satisfied, happy, and content that we put forth a budget that was really what we needed. And the hospital board chair chimed in to say, I think we're always going to ask for what we think we need, even if it's over your guidance. I can tell you, we would make a very compelling reason as to why, and it'd be thoughtful and purposeful. So, you know, it's not like this is new or that we haven't talked about this stuff before. You know, it's definitely come up. And so I'm not crazy. I have some receipts. And then just to remind everyone how we frame this in the guidance, this is directly from the guidance as approved, fiscal 24. I'm sorry to read so many slides to people today. The fiscal year 24 budget guidance incorporates the net patient service revenue, fixed prospective payments and reserves, benchmark established in the fiscal year 23 guidance. Hospitals' budgets will be reviewed for compliance with the NPR benchmark. Hospitals whose budgets comply will be reviewed for reasonableness of the factors and assumptions outlined in the guidance, which is talking about different expense drivers, and compliance with the filing requirements. So are they on time and complete? Staff will recommend approval without modification for all hospitals' budgets that are able to comply with NPR benchmark and are based on reasonable assumptions and meet our administrative filing requirements. So if it was on time, you're within the guidance, staff will recommend an approval without modification. Hospitals proposing budgets that exceed the benchmark must provide evidence to support the need for the additional NPR, which will be assessed by the GMCB using the factors set out in the expense part of the guidance and consistent with their statutory obligations. And then we will also consider the narrative, which is being submitted. So that's what section 2 has. Where did that target even come from? Like 8.6, I'm sure you pulled that out of some hat, right? Well, we did in some ways. So it's, you know, a performance target that the state of Vermont has at large for its per capita growth and total cost of care. The way that they selected that measure has to do with how Vermont's gross state product was growing. And that was the difference between a 5 and a 10-year look back, and essentially how influential the 2008 recession was in that indicator. And that's where that range of 3.5 to 4.3% annual growth is, and where the guidance extended that for 2 years to be 8.6%. The idea was to use a consistent target that aligns with the state's longer term goals. It wasn't to say that it was, you know, the gold standard, but that is as a state what we've adopted. So that seemed like the logical comparison point based on that trajectory. So what happens if a hospital can't meet that, which we think is very likely? We will review every submission for regulatory compliance and the assumptions that were used to build that budget. If a budget does exceed the benchmark, we'll just take an extra close look to see how hospitals already tried really hard to minimize the burden on ratepayers. And I think, I mean, I'm not a board member, but I think increases due to Medicare reimbursement, additional efficiency, I don't think that anyone would probably have a problem with that. It's when we're trying to, we just want to make sure there's evidence about what would be expected based on commercial rate. And to put this in a slide, so this is kind of just the process. So it'll come in, is it within the guidance? If so, are the assumptions supported in the submission? Okay. The rate request, do we have evidence for that? The staff would say approve that one as submitted, but along the way, if we have some questions, it's just what's the support look like? Do we have questions? Can we kind of isolate those sticking points out together? But again, the real intent here is just to make sure that, ensure that efforts were made, that the price being paid by commercial ratepayers is something the board can understand. So that's kind of the bulk of the directly related material that I had for the board today. I did want to put in some other data points here just to help put this in context, because unfortunately, the board doesn't make any decision in a vacuum, and they have other regulatory responsibilities and concerns that they're constantly balancing. And I would say anyone can look through that incredible public comment to see just the range of hard problems that the board's grappling with. I think it's striking. But at any rate, so qualified health plans are the things that you would get on the exchange. And so whatever, if you are a beneficiary, a member, a subscriber of a QHP, you pay a premium every month. And some of what that premium is designed to pay for is hospital care. And some of that hospital care that's provided happens in Vermont. So QHP premiums, hospital rates, totally different things. But, you know, we want to be clear that, you know, both things are going up and both affect what Vermonters might be feeling. So again, this is not a direct connection to hospital budgets, but just something we want to put in context. And so one is that Vermont has something called community rating. So that means that in order to try to even out drastic swings in the cost of your healthcare over the course of your lifetime, it tries to balance it out. This adds more credibility to the population to make it easier, or it's never easy, but tries to add more credibility to spread that risk out when we have a small population. And so on the left-hand side, you'll see states that are on the federal exchange. So there's 33 states there, and how, relatively speaking, a 27-year-old is going to pay a lot less in premium than a 63-year-old in a typical federal exchange state, whereas Vermont, you can see, splits that difference. And so it's a screaming deal for a typical 63-year-old, but is a really steep bill for a typical 27-year-old. And so I think that's just like an important point when we think about QHPs in this state. But all that to say, so this is from something called the Uniform Rate Review Template, fun times. And what it is it tries to, for a starting index rate for a commercial plan, there's these different buckets of what the premium is paying for. So some of it is hospital services. Professional is like when you actually see a doctor for their actual service expense. Other medical and capitation is a small category, which is why you see some really funky numbers in that, but that's some of the payment reform activity in the state. Pharmaceuticals is another big driver. To be clear, these would be ones covered by the medical benefit of the insurance plan. And then those overall kind of total increases. So in this time period from 2017 through the rates, the experience period index rates submitted for plan year 24, we saw an overall increase between 53 to 83%. That's going to vary depending on the type of plan you're in, individual versus small group, and potentially who your insurer was. But the subset that is associated with hospital payments was 37 to 87% growth, so quite a bit of variation. And to be clear, that's not at Vermont hospitals. And I'd say from what I'm seeing in the commercial market, we are seeing, you know, more and more care having to go out of state, or, you know, choosing, who knows, no, not implying causation, more dollars are showing up out of state. That's all I know. At any rate, I want to be clear that of that hospital column in the 24 rates, that's 49 to 63% of the total premium. So it is a substantial portion of the premium, even if the growth rate hasn't been the most dramatic. So definitely see those rates going up. And then this is, we've seen this one, I think, a couple different times, but this is looking at kind of comparing some selected changes in inflationary price changes over time since 2000. Hospital services grew at 227%, and other medical services at 132%, whereas the average hourly wage grew by 104%, and overall inflation grew at 74%. So just seeing some dramatic growth based on that kind of analysis. And then just broader landscape trends. So Vermont does have quite a low uninsured rate compared to nationally at 2.6%. But however, you know, people do remain uninsured due to the high out-of-pocket costs that impede their access to care. And many are considered underinsured, meaning that even if they have insurance, it's not a sufficient coverage then that their household income can bear. And then here's an old, or not old, 2021's yesterday. But anyway, the HCA produced a report that affordability issues comes up in nearly half of their cases. I wouldn't be surprised if that's grown. I didn't have a chance to update that with them. Sorry. So here is a potential motion language, based on conversations that I think is where we're headed, but happy to entertain questions, comments, concerns, feedback.
Thank you very much, Director Lindberg. It was really helpful to see all of that in context. I'll open up to board member comment, and we can start. Dr. Merman, if you have any questions or comment.
Sure, Chair Foster, thanks. Sarah, mostly comment. But I want to thank both you and Russ and the hospital budget team. I know you guys have been working really, really hard with this transition to the new way of doing the hospital budgets. And I know there's a lot of work going on now to try to finish off the guidance and get it to the hospitals. And I know that this has been a big lift for you over the last couple of weeks to do extra work here. So thank you for doing it and putting the time. I really appreciate it. I think that the VOZ request has really, I think, been very important because it's brought a lot of attention to this very complicated issue. It really highlights the challenge of the Green Mountain Care Board to balance cost affordability of healthcare with accessibility, quality, and sustainability. And 98 public comments on this. I think I agree with you, Sarah, really did run the gamut of public views and all of the things that we're trying to think about at the Care Board to try to balance these things. We had engagement from hospitals, small businesses, independent providers, and insurer, patients, advocates, all giving comments. So it gives me hope, I think, that together we can draw on these perspectives and experiences and make progress. But that said, the first batch of letters we received was largely from hospitals, representative hospitals, and presumably advocated by hospitals. They shared much similar language and statistics, and as well as the Vermont Association of Hospitals and Health Systems, VOZ. And these comments brought out themes of concerns of high inflation rates for hospitals, everyday expenses and supplies, labor expenses, large amounts of temporary workers at places. They advocated for the unique aspects of hospitals, their importance in the communities, the complicated issues with increasing utilization, pharmaceutical cost increases, and quoted our guidance discussing the importance of considering national, regional, or in-state peer group norms according to indicators, ratios, and statistics. And they also, many of them discuss the need potentially to cut core and basic services of these nonprofit organizations if they had to follow the guidance as written from their perspective and what they see. And when I started reading these letters, I was kind of struck by how I felt like I was reading letters that were referencing a different guidance than we had just completed our discussion on. I honestly kind of felt like almost a little embarrassed because I felt like these were so far off of our conversation and what we were talking about, and that there really wasn't people that didn't really address after the part of the 8.6% increase for NPR. And after that is, I think, the really important part of the guidance. And I just want to directly read some of this because I think it really addresses most of the hospital's concerns that they outlined in these letters. It says, if a hospital budget exceeds, and Sarah just read this, but if a hospital budget exceeds the NPR FEP growth guidance, the board will review the specifics and support for that NPR FEP growth provided by the hospital in its FY24 budget submission using the factors and criteria set out in this guidance. If you flip the page, on the next page, it lays out the factors and criteria. Labor expenses, utilization, pharmaceutical expenses, cost inflation, commercial price changes, financial indicators like margins, days cash on hand, debt service coverage ratio, things that make up bond ratings, which were brought up in the public comment: Medicare, Medicaid price changes, uncompensated care, productivity and efficiency indicators, administrative costs, cost per discharge, salary allocations, ratio of administrative salaries and expenses to clinical and other expenses. All of these are to be compared against national, regional, or in-state peer groups according to indicators, ratios, and statistics. So I feel like many of the things that the hospitals and the advocates of the hospitals, and I really appreciate their engagement, but they were really written already in the guidance. I don't know exactly how this came to be. It almost seems like there was some misinformation regarding the contents of the guidance, because it's written right there, as well as the board's public deliberation. When we discussed this, we discussed how that for hospitals that come in under the guidance, under the 8.6, there'd be a fast track approval process that they just have to meet the, have actuarially valid or valid budgets, essentially. So that was fairly concerning, I think, to me. And as I continued to read these letters, I actually moved more from a feeling of kind of almost embarrassment for the lack of reading through the diligence of reading through this, to really feeling very disappointed that there was something really missing from each one of these letters. Every single one of those 38 letters did not mention where money would come from. There was a request for money, but no acknowledgement of where the money comes from. One letter even implied that the Green Mountain Care Board can provide aid. And I assure you that the Green Mountain Care Board is not an aid organization. We cannot provide aid to hospitals. When hospitals grow beyond what's reimbursed by public payers, the money comes from either pulling from other parts of the health economy or raising commercial insurance rates. This was not even addressed in any of these letters. Most of the other letters that we did receive did address this topic, and with quite a degree of concern. So the other components of the health economy, such as independent providers that wrote letters, physical therapists, don't have the market power to negotiate large increases in payments. So without increasing commercial insurance rates, we would shift money from other parts of the health economy that are really important for us to survive and maintain. These are high efficiency, low cost practices that are struggling to survive, and they're working every day as hard as they can to provide care for their patients. I just think it's hard for me not to address the commercial insurance potential cost of increasing revenue. Again, it's not a one-to-one, the cost of insurance is not directly hospital care, but if a hospital needs more money and it's, and they're asking for it to come from commercial insurance, that goes directly on to Vermonters, small businesses, individuals who are trying to make good business decisions on a daily basis. So I do support our guidance. I do expect hospitals to come in. I do support our guidance. I do expect hospitals to continue to provide their core services. I'm not particularly moved by the argument that there's so much out of their control, because we see peer organizations that have an ability to control these things. I think that they need to continue to work really hard to get these things that are not in their control into their control. And I'm sure they are. In fact, many of the letters did discuss many of the hard steps they are taking. I think that the guidance is fair as written, and I think it expresses many, if not all, the concerns the hospitals have written in their letters. I think it's very important for all of our hospitals to be sustainable and all of our healthcare providers in Vermont to be sustainable, thriving members of our communities. But I really think what lifts us, what really improves the healthcare of Vermont long-term is a healthy economy. And continued commercial rate increases, I think, are going to be very detrimental to our economy. So those are my comments I have. Thank you, Chair Foster.
Thank you, Dr. Merman, for your thoughts. Member Holmes, did you have any questions or comments?
No, I don't have any questions. I just have a couple of comments. Again, a thank you to Sarah and the team for all the hard work and continued hard work on this. I know we have a long summer ahead of us, so we appreciate all that you do. I also want to echo some of Member Merman's comments about the public comment we got I appreciated the numerous comments that we received. Almost 100 people, took time to share their views, and it was great to see such broad engagement. I actually really hope that people continue to engage the process during our budget hearings, particularly I think the hospital trustees, where we've seen a lot of engagement in the last few weeks in this process, more than I think we've ever seen before. And I was thinking about, given this heightened level of engagement by the hospital trustees, I think it is really important to see information about our hospital budget process and the factors influencing our decisions flow more directly actually to those trustees. We should make sure the trustees see the same data that we do about their hospital's relative costs, their relative prices, relative efficiencies, productivity, all of the data that we're gathering this year to help inform our decisions. I think it's really important for them to understand all the factors that weigh into our decisions. So I think that might be a process step going forward that would be really helpful. As for the decision before us today, last year the board laid out a 2-year NPR target in response to hospitals actually who wanted longer range budget guidance. So that was in response to their requests for more longer term planning, which I think, at the time seemed like a reasonable request. As we made clear in March, though, this is guidance. It's a target. It's not a fixed and immovable mandate. So we're going to evaluate each hospital's budget submission on its own merits, as we always do. If the 2-year NPR target growth is too low and the hospitals can justify their higher submission with data and compelling evidence and comparatives to benchmarks nationally and regionally, that makes sense. As we do every year, we're going to assess, and in some circumstances, we may approve higher than target NPR if it's been adequately justified, as we have in the past. So I think it was laid out in the guidance as Sarah read, and as my colleague Dave Merman also read. It's very clear in the guidance what we will do if the NPR exceeds our target. And I guess I would just say, speaking only as one board member here, but I suspect I'll be more sympathetic to a budget that exceeds the NPR target due to higher Medicaid and Medicare reimbursements, perhaps, or utilization growth, not commercial rate growth. In terms of utilization, we see patients all over the state, myself included, frankly, who have been waiting months to see a specialist or get a diagnostic test. So if a hospital is exceeding guidance and they submit a budget that reflects higher utilization due to greater productivity, improved throughput, shorter wait times, it's going to be easier for me to approve that. We also want to see budgets that reflect focused efforts on reducing unnecessary or potentially avoidable utilization, especially given that we gave this 2-year window and there's been data out there about potentially avoidable utilization. So I think that would be helpful to see that hospitals are trying to reduce some of that unnecessary utilization where it exists. If there are areas of the state that are experiencing high population growth, that may also justify higher than targeted NPR growth. But I do agree with my colleague Dave Merman about if the overage is due to double-digit commercial rate increases, particularly after last year's unprecedented rate increases, that's going to be a harder sell. The point is, commercial rate can't be the only way we have to plug holes. Vermonters can't afford it. So we need to see significant efforts to cut costs, improve throughput, improve efficiencies to make those margins. But as I always have done in the past, I will look at every budget that comes in and all of the data that support and justifications that support it on its own merits. I will evaluate it. Whether it conforms to the guidance or not, I'm going to look at all the data that's submitted. So hopefully that gives some relief to hospitals that we're going to give it a fair shake. And my hope is that given the current financial vulnerabilities of our hospitals, which are indeed accurate, our hospitals are struggling right now, not only in Vermont, nationally as well as households, families, businesses are also suffering. There's a healthcare affordability crisis. Both of these are happening simultaneously. So I look to this Act 167 community engagement work as an opportunity to find a better path forward to sustainable hospitals and affordable healthcare. And so I'm hoping that hospitals and the communities will really fully embrace this work as we go into the future. So where I stand right now is I support keeping the fiscal year 24 guidance as it is, not waiving enforcement, but recognizing, as the guidance lays out, that we will evaluate every hospital budget on its own merits. So those are my only comments, and thank you to Sarah and the team for all of your hard work on this.
Thank you. Member Lynch, I'll turn to you next if you have comments or questions.
Thank you. And again, I'll just echo my colleagues' thanks to our team and also to everyone who submitted comments. I don't have a whole lot more to add. I'm supportive in maintaining the guidance. I think, as I said when we were discussing it earlier, this lays out a process. And given the volatility that we've seen since the pandemic, during the pandemic and since the pandemic, picking the right quote unquote number is really not feasible. So I think sticking to the commitment that the state made as sort of a long-term target is a rational place to go. Also on the enforcement, because we have only waived enforcement during the pandemic, I do think that is an extreme measure. As Jess talked a little about in terms of prior board action and weighing each individual hospital budget, I think that has also, you can say the same thing about enforcement and weighing the particular circumstance behind, what was driving the issue. And certainly, I think we recognized that when you have volatile situation, that it's difficult to predict, and the budget is a prediction of where the hospital is hoping to manage to over the course of the next year. So I'll stop there, but I'm supportive of maintaining the guidance and not waiving enforcement.
Member Walsh.
Thank you, Chair, and thank you, Sarah and team, and thank you all for the public comments. I don't have a lot to add beyond what my colleagues have said already. I think their responses have captured a lot of what my thinking has centered around. In reading through the public comments, a lot from the hospital side centered on inflationary pressure. And the graph that Sarah showed late in her presentation on hospital prices and medical prices show us that Vermonters have been facing greater inflationary pressure for their healthcare services over a longer period of time. Hospitals are citing double-digit inflation the last couple of years. Vermonters have been under greater pressure for longer. In any other business, if prices just keep going up, eventually the consumer could go elsewhere. But this is healthcare in Vermont. And we're not talking about consumers, we're talking about patients. And we're talking about a small system, relatively small system. Patients can't go elsewhere. Our healthcare system is becoming less and less affordable. An unaffordable system is not sustainable. It's not a trade-off of one or the other. An unaffordable system is not sustainable. So, like other businesses, when we cannot keep raising prices, we need to look at how do we better manage our expenses so that we're delivering care or services in a way that the market can bear. Okay. Over the past couple of years that I've been involved with this, year and a half, the request from providers and health systems has been for more predictability and certainty. Last year, in an attempt to do that, we gave a 2-year target. Many hospitals, well, some hospitals exceeded that target in the first year. Now hospitals are requesting greater adaptability. And it gets to a point where it seems like the only correct rate would be to concede to the requested rate. And that's not the role of regulation. So I'm in favor of keeping the target as set. I will, of course, as my other colleagues said, review every budget as it's submitted. And as Dave so nicely pointed out, all of the factors that we will consider, I will consider those with an open mind, but as it is, I see no need to change the guidance. So with that, I'll turn it back to you, Chair Foster.
Thank you. I'm largely in agreement with the other members. I did want to thank all the public comment. I think I read every single one, some multiple times. I appreciated the hospital and the hospital board engagement, and also the non-hospital providers and public and businesses. It was really robust and valuable. And I know that Director Lindberg and her team were working overtime a lot the last couple of weeks. So thank you guys very much. The hospital request is fairly extraordinary in that it asks the care board to depart from established 2-year guidance. And I'm sure that request was not taken lightly. And I appreciated many of the points raised by the VAWS submission and by the hospitals. In particular, the concerns surrounding hospital financial situations, nursing shortages, physician shortages, cost of supplies, and other inflationary pressures. But as pointed out in the public comments, those challenges are not isolated to hospitals. And we are seeing independent practices having difficulty keeping their doors open. We're seeing Vermonters avoiding and delaying care. We're seeing escalating insurance premium costs, rising underinsured rates, and home health, independent specialists, primary care, FQHCs, and the whole entire system struggling with retaining staff, including physicians, nurses, and PAs. Hospitals have again raised concerns about cutting services. There was at least a couple letters, I think, that took the language regarding cutting services as a threat from hospitals to the Green Mountain Care Board. I'm not willing to go there, and I'm confident that our hospitals know better than to use tactics like that. However, hospitals have previously indicated that in their view, they would have to cut services if the Care Board did not agree with their budgetary requests. But at this stage, with this submission, there was no underlying analysis to support that claim. So it's difficult to evaluate without that sort of work through of the various options available. So if VAWS or the hospitals want to provide the board with the analysis that's been performed so we can understand the issue more granularly, I would request that. I think it'd be beneficial because alone it's kind of hard to see. But in any event, what's been presented to us, it's unclear whether the choice is as binary and as stark as presented. Either give hospitals the money that they request or cut services. And I hope those are not the only options. And I would like us to collaboratively think about whether or not there are other options, because I don't think we want that for Vermont at all. Vermont Hospitals NPR, I think one of the slides that Sarah had, indicated the NPR has grown hundreds of millions of dollars over the last 5 years. I think it was over $500 million. And QHP plans have gone up 50 to 80% in the last, I think it's 6 years. That's really, really a large amount of money. There's public comments suggesting that Vermonters are not willing to pay for healthcare services. And I don't see that. I see the opposite. I see Vermonters making sacrifices in their household budgets and working tirelessly to afford the healthcare system they need, but are challenged in accessing despite the hefty financial investment. So I think Vermonters are bending over and really working hard to try and afford this system and support it. So I applaud Vermonters for that effort, and I know it's not easy. Given the acute financial realities we collectively face as a healthcare system, we need an integrative and collaborative approach that considers the whole system. This request, however, did not address a number of key issues. And I was struck by what Member Merman said because I felt the same thing. Some of the letters, the term I had in my head was it's like an echo chamber of misinformation, because a lot of what's actually being asked for is in the guidance. That was the point of the guidance, but that wasn't really brought to bear sort of in this process. And I think those, when you start looking at those, they are really fair. And that's what we want: objective, predictable, and national. So we have it. But some of the key things that I would need to support the hospital request were not included in the submission. And I'll highlight a couple of those. First, where the money hospitals are seeking us to approve would come from. As I think Member Holmes and Merman said, if it's based on increased utilization and throughput, that's one thing. If it's solely on commercial, that's a very different question. And the request did not identify or discuss the financial pressures Vermont businesses and ratepayers have been under for the last several years, which was highlighted in a lot of the letters that we got. Second, from the submission, it was unclear to me how the monetary increase that was requested would fit in with our goal and task as care board members to promote an affordable, accessible, and high-quality healthcare system. And last, the submission did not include an assessment or any indication or reference at all to whether or not there's an impact on hospital increases to other providers in our system. Because I am of the view that we need those too. We need the primary care, we need home health, the FQHCs, mental health, all of those. And some of the comment indicated that there's concern about the ability for those non-hospital providers to obtain rate increases. And that assessment wasn't included in the submission. So for me, the submission didn't provide the basis I would need to amend our guidance. I have several questions for the requester, but at this stage, I don't feel that I need to ask them. But they really go to some of those public comments and how we should assess affordability. And one other issue that Tom Walsh raised, which was, how should we set our hospital budget guidance? Does affordability have a role in deciding how much money we should increase the hospitals? Or should it be the other way around, which was the hospital financial need dictates what we can afford? And that then goes back to the point of where the money is coming from. And it's certainly a lot more palatable if it's not on the commercial ratepayers at this point, given those large increases we've seen in the last several years. So with that, I don't have anything else, and I also support the guidance that we have as written. And with that, I'll turn it to the healthcare advocate.
Good afternoon, and thank you. And I will echo the same appreciations to all of the parties, to the board staff, and to all the commenters. And also to the board members. I very much appreciate the conversation that's been happening for the last little while. The HCA has been clear in our written comments, and we've been clear in our verbal comments in previous meetings, and we stand by those comments. Sort of in the nature of the conversation, a few of you have made a point about how Vermonters respond when they can't pay their bills and need care. And our work in exploring medical debt and Vermonters' voices around medical debt backs that up. Vermonters told us again and again, they appreciate their providers, they want to pay their providers, they feel embarrassed. And their only answer often is to not go get more care because they don't know how they'll pay for it. I know none of us want that. Again, we stand by our comments. We appreciate the conversation, and we support a motion to deny the request for a change to the guidance at this time. Thank you.
Thank you very much, Mr. Fisher. I'll open up to public comment before we see if there's a motion. And I'll just use the raise your hand function. I'll call on folks. Ms. Gutwin, please go ahead.
I'll be brief. First of all, I've never been so impressed and proud, Sarah. Great job. And each and every board member, I thought your comments were reflective of a lot of reading of public comment and absorbing that and coming to the conclusion you have. I want to anybody who's online now from the hospital, if they want some help in meeting a budget, I think that there's a lot of people that can help you right now. I am one. And reducing salaries to the top end, the managers, the administrators, is one of those ways we have managed our budget. It isn't unreasonable to go to those in administration and look at their salaries and really reflect if that's really what the healthcare system needs and the amount of people in the upper managements. When I took over the rehab gym, I came from the hospital when the hospital had a hostile takeover of the SRC. And in one movement, the hospital went from I needed to fill out one piece of paper to 5 pieces of paper in 15-minute meetings with patients. I suggest another, because this is a way that I save money, is go to the frontline workers, find out what it is that they need to do their job and build them up. Ask them, how could we do our work more efficiently? Do we really need all of the extra work that goes outside of direct patient care? I do believe that you're going to find a wealth of savings in the budget, and I welcome a conversation with anybody of the hospital at finding ways to reduce expenses. Thanks.
Thank you very much for your comment, Ms. Gutlin. Mr. Del Trecco, please go ahead.
Thank you. So Sarah and team, thanks for your work on this, and thanks for the board members for taking this up today. I think today's proposed motion for the discussion we've been having is disappointing. And I think it's concerning for the impacts that it will have on care for Vermonters. I think I think we agree on many things, and I think we may not agree on how we are looking at some things. So this move, no matter how much it's couched in the notion that healthcare costs too much, is something that I completely agree on. But I don't think the discussion around how this will lower premiums is something that I agree with. You know, not running hospitals in a way that provides access to care, quality, and having the availability of primary care and specialty services that we need, and we already know that are very challenged, will frankly increase costs over time, harm our workforce, and put vital services in jeopardy. And Chair Foster, that is not meant to be a threat or anything of that nature. I am much more collaborative than that, and it's not the nature of how I operate. And I know that it's not your intent of the board to create harm, but I think this will be the outcome. You've mentioned a couple of times on the 2-year increase of 8.6. I don't disagree that that's what was agreed upon, but the economic reality of what's in place and in front of us hasn't changed. And if you go back to the decision of why that occurred, it was because of some of the economic forces that were in play. So for me, the math is simple. Our own hospital data and national studies look at double-digit expense growth. And guidance that essentially leaves us at 0.1% today is so far out of alignment with that economic reality. And I'm disappointed that you as a board haven't addressed that today. It's what our entire discussion to you has been. And I've never seen guidance that's so disconnected from what's happening on the ground, and it concerns me. If patients aren't able to receive care in Vermont, they do one of two things. And Sarah mentioned we're seeing a migration out of state, no causal effect, but those that can go out of state will. So that's those with means will leave and go out of state. Patients without the means will likely delay care and show up sicker and in need of more services, already challenging our emergency rooms and inpatient floors. In either situation, Blue Cross Blue Shield, MVP, Cigna, Aetna, United, pick your commercial payer, will end up paying likely at higher amounts for this care. This comes at a cost to Vermonters, both mentally, emotionally, and financially. So there's the other side of the equation that hasn't been discussed. Even in today's hearing, staff acknowledged that this guidance will be very difficult to manage. It also is referenced impossible to meet at times. So I'm not sure of how you hold to your decision as it's so far out of alignment with what's been publicly shared. I have to say, the people that I work with are amazing. Our hospitals are good stewards of resources. Where many other entities have abandoned investing in solving community problems, our hospitals have consistently stepped to the plate. There's no organizations that are investing in housing like we are. There's no organizations investing in food insecurity and improving delivery throughout the state. We actually stood up a reform model without any help. That's incredible work. We shouldn't be punished for that either. So as we move forward and I think about this decision, you know, what I see happening is challenges compounding community issues, increasing or challenged stress around mental health, housing, long-term care, and transportation programs. These are things that we invest in, and we will try to continue to invest in to the best of our ability. No other organizations do what we do. Independent practices, I embrace their challenge, and I would love to talk with them. Our request is not to take away or move money from them to us. Our request would to be raise all boats. We are the place of last resort for Vermonters, and mostly when they're at their most vulnerable moments. And placing hospitals at further risk will jeopardize that. And again, it's how we're thinking and talking, and it's not a threat. It's how do we manage in this situation? I recognize that Dr. Merman and others talked about guidance. There's so much uncertainty on how you will measure some of those things as you evaluate our budgets, and it's very concerning. There's no information on what's acceptable or not acceptable, what's good or bad, and that's problematic. So in closing, as requested in our May 3rd reconsideration letter, I'd love to request from you a formal letter that outlines your decision as you make it today. We deserve this in writing. We specifically want to know how you conclude that a 0.1% growth rate meets the true economic realities, not what you agreed to 2 years ago. Things have changed dramatically, and inflation is still locked in. So when we asked for consideration, I did so on behalf of organizations that equitably care for all Vermonters, no matter the condition or the circumstance. We did this, you know, when we think about this, we did because of the overwhelming concern that I have around the viability of these organizations. And I think somebody on the call mentioned the economy is a big driver, and it's the other part of my concern. The economic reality of challenged hospitals is a real thing to these communities. These are good paying jobs. These people live in communities, invest in their communities. And it's the other reason why I made this request. So your decision today, whatever it may be, if it's the motion that is in front of you, I think does further disservice, adds more moral injury to the caregivers that they are already experiencing. And I certainly look forward to your response letter. And I still offer my collaboration to you because that's how I operate. And I think we've demonstrated that in our conversations. Thank you.
Great. Thank you very much for your comment, Mr. Del Trecco, and for the submission. Is there any other public comment? Mr. Hoffman, go ahead.
Thank you, Chair Foster. The board is to be applauded. I'll reference Dr. Joseph Paris's words to this board a couple budget seasons ago during the ACO budget process. He acknowledged that if reform achieved anything, it was essentially the Green Mountain Care Board's budget maintenance through the hospital budget process that had succeeded in bending the cost curve as set out in the all-payer model. Dr. Merman saliently pointed out that the 8.6 over 2 years was in response to the hospital's request for predictability. And unless VAHS and its constituents are essentially conceding that the all-payer model has failed, the board is being applauded today for maintaining what achievement there can be pointed to in the all-payer model in bending the cost curve. I think 600,000 Vermonters would take deep offense to the idea that they did not stand up the all-payer model. Mr. Del Trecco would lead everyone to believe that the hospitals singularly did that. That was on the backs of tax and ratepayers who succeeded in funding such an experiment. And for their efforts, what they've received are year-long wait times to specialist and primary care practices, high costs in their premium payments, employers unable to reinvest in businesses because all of their money is going to healthcare costs, school districts raising taxes while ED utilization exceeds peer ACOs by 36%. So we can't applaud ourselves for standing up a reform that really has never realized the value that was supposed to be generated in a higher value, lower cost setting, utilization of healthcare resources, which it's actually great that Mr. Del Trecco pointed out these hospitals, and again, it was, in my view, despite his contextualization of it, a further threat that perhaps PCP and specialist care could be cut. And I would tell you all that that would be a great outcome. That care can be redirected to the dozens of independents who have reached out to you saying, we stand here willing and able to provide higher quality, lower cost care in the state, if only you'll make the playing field level. So the reality is that VAHS speaks on behalf of 2/3 monopoly that controls the system in Vermont, that commands 300% of Medicare above and beyond what Green Mountain Surgical Center or Vermont Health First can command similarly. And so I would encourage you all, take him up on his offer, allow this monopoly to get out of the business of charging premiums for higher costs, but no commensurately better care amongst primary care and specialists. Let them exit that space and return to their core business of providing acute and tertiary care. The academic medical center does provide a value in the state as the only AMC. Let them provide innovation in new care, new cancer treatments. Let them focus their efforts there, but get them out of the business of charging excessively high premiums for care that could be provided elsewhere. Thank you.
Thank you very much for your comment, Mr. Hoffman. Is there any other public comment on this topic? Mr. Davis, how are you? Please go ahead.
Thank you, Mr. Chairman. Very interesting. I think it's still strange to me that that neither side, so to speak, and I think they are sides, really getting at the ultimate issues. The real issue here is that the state of Vermont, with a little over 600,000 people, has 14 full service hospitals. They're doing hip replacements in critical access hospitals. Several of them at way under the leapfrog numbers for minimum quality expected. You really can't. I think your decision today is obvious, and I actually totally agree with it. The thing is, is what Mike Del Treco puts out is it's hospitals versus regulation. There's the problem is that there are too many hospitals, way too many hospitals. We don't need that many with full service until you figure out a way. To take tiny hospitals, prevent tiny hospitals from doing stuff that's too sophisticated for them to manage, then this whole problem is going to continue. And I think we've done reform here. Really, the modern reform started in 2012, but the real reform itself started in the early 1970s with the former Governor Dick Snelling and then Gretchen Morse, who was a very young legislator then. We're close. We have our costs really nationally are good, okay, but we're not going to get reform until you look at the data that is just all over the October 27th data. It never gets mentioned here. It's never seen. The quality of the hospital, the care that's delivered to all the by all the Vermont hospitals has been measured more than once by consultants. Okay, the quality in those hospitals is dramatically different. Now, maybe you can argue with them, but it never gets mentioned. Here's what I'd like to ask the board the members that were here in 2019. Why did you get all those consultants to do all that work and bring them all in after a year or two, and they just poured information into your system, and you never mention it? You people are just hiding from it. You're not going to be able to stay away from the issue that you've got to reform the structure of this system before you get the costs under control. You just cannot do it any other way. So that's my view. I'm sorry. That's all I have to say.
No apology necessary. Thank you for the comment. Hang on, Mr. Davis, your hand's back up. Did you have something else?
No, I have no idea what I'm doing.
Okay, no, you're good. You're good. All right. Well, thank you. I think this issue today is really on this particular request. But I'm the chair of the care board now. I think one thing we owe it to the public is to be really honest and transparent and upfront. And I mean, we're here at every hearing. We're kind of an open book. But to your point, Mr. Davis, maybe there is an appropriate time to talk about that or look at that, because I don't think anyone here has any intention of hiding anything. I think we lay our cards out really fully on the table, and I'm going to keep it that way. So thanks for pointing that out. And certainly there may be an opportunity to look at what you're referencing. So thank you. I think we're ready to vote. I don't have the specific language, although I can come up with it. I move to deny the VAWS request to, here, I'll use this. Sorry, I'll start over, strike that. I move to deny the request from VAWS to modify the Green Mountain Care Board's fiscal year 24 hospital budget guidance, and also deny the VAWS request to stipulate to non-enforcement of actual 24 hospital budgets.
Second.
All those in favor, please say aye.
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 The vote carries unanimously. And thank you, Director Lindberg and Mr. McCracken, very much for all your team's efforts and work. Next on the agenda is the vital budget, and Jess Mendizabal, who has been recognized with the Public Service Recognition Award this year, and I'm extremely proud of that, will present the vital presentation. Thank you, Jess.
Thank you. I'm going to go ahead and share my screen in just 1 minute. Okay, there we go. Everyone can see okay? You're okay?
Looks great. Sounds good.
Okay, great. So thank you again, Mr. Chair. For the record, my name is Jessica Mendizabal, and I am a director of data management at the Green Mountain Care Board. Today, I will provide a brief overview of the board's oversight authority related to Vermont Information Technology Leaders, or VITAL, which is Vermont's designated sole health information exchange network. I will summarize VITAL's budget submission, which was presented on May 17th, and I will provide a staff recommendation. After the budget portion of the presentation, my director, Kate O'Neill, will present an amendment to the Health Information Exchange Plan, also for the board's consideration. So just to remind everyone, as part of its oversight and policymaking activities related to health information exchange technology, the board is required to review and approve VITAL's budget annually. This authority came to the board in 2015 and was first exercised in 2016. The board's oversight is intended to provide strategic guidance and policy parameters. This slide is a summary of VITAL's FY24 budget submission. All the detailed materials were provided by VITAL and available on the Green Mountain Care Board website. Just quickly, revenue includes state funding through a contract with the Department of Vermont Health Access. And in FY24, the revenue accounts for some project work that is shifting into this next fiscal year from previous years. Non-state funding reflects some potential changes to contracts and program fees. Major expenses do include labor, which includes one new position, potentially in technology, as well as some outside support, which is consultative work for projects, specific projects, and an additional expense, major expense, including software and server maintenance. So staff review the VITAL budget against the criteria that is established in the budget guidance, which was approved by the board in April of 2021. That's also available on GMCB's website. In the following slides, I'll walk through these criteria along with the staff assessment of whether the criteria were met. So the first criteria is that the review process will be transparent. Transparency is measured by compliance with the budget guidance and overall transparency of the budget process. Staff have found that VITAL has complied with the budget guidance, and the budget was submitted in a timely manner and included all requested components. VITAL also responded timely to all written questions about the budget and addressed those questions in their presentation to the board as well. The narrative, the budget documents, and the most recent audited financial statements are also posted to the Green Mountain Care Board website. The second review criteria is that the process incorporate public input. So staff find that VITAL presented at the May 17th board meeting and responded to comments and questions from board members at that public meeting. In addition, we held a special public comment period. It was open from May 17th to May 29th, and we did not receive any additional written comments. The third review criteria is alignment with the Health Information Exchange Plan goals. The criteria states that the board will review VITAL's budget to determine whether it reflects a strategy and priorities that are consistent with the state's healthcare reform goals and the HIE plan. The board will not direct the technical details of VITAL's work or the details of VITAL's contractual relationship with the state. Staff find that VITAL's budgeted activities will advance the goals of the 2022 update of the HIE plan, which was approved by the board in December of 2022, and that is also available on the Green Mountain Care Board website. Staff also find that VITAL's budgeted activities will advance the goals of the HIE plan by providing foundational, exchange, and end user services. And these reflect the Office of the National Coordinator for the Health Information Technology Framework, which the state's HIE plan relies on. The budget submission includes a table referenced on this slide, which categorizes Vital's revenue, the revenue sources, and the major projects by service category. The final review criteria is that the board's review process must be structured and timed in order to assist DVHA and Vital in negotiating timely and effective agreements each year. So staff have worked closely with DVHA and Vital in preparing the timeline for this year's budget review in order to ensure that the review timeline did not conflict with any federal contracting requirements for DVHA's agreements with Vital. In addition, staff will ensure that written decisions stemming from this budget review are sufficiently clear. So given the findings, staff recommend approving Vital's FY24 budget as presented with 2 conditions. The first condition is that in addition to any reporting requirements that are outlined in the budget guidance, quarterly reporting should include updates on Vital's strategic planning process and progress, including any work to design a future financial model that would diversify revenue sources, any key projects, including patient education and consent, as well as expanding the data available in the VHI, responses to recommendations from the Health Information Exchange cost benchmarking work underway with the Department of Vermont Health Access. And the second condition is that Vital will comply with the mid-year budget update requirements as described in the board's annual budget guidance. So we have some suggested motion language here. I will pause to see if there's any questions or any discussion at this time.
Thank you very much. I'll open up to any board members that have any comments or questions.
I just have a brief comment, which is to say that I think the conditions highlight some of the areas that are evolving. And so I like the idea that we're going to be able to get information about those evolving issues over time. So thank you both for thinking about that.
Any other board members? I don't have any either.
Yes,
Al? Okay,
I would add one quick comment, which is I support the approval of the budget, but I also think that we should think over time what the most appropriate intervals for reporting back to the care board are. I mean, I think Vital is largely governed by AHS, and I think if we can, I appreciate the updates, I really do, but I don't want to add burden for things that we don't have actionable items on. So I wonder if we could sort of engage in a discussion at some point about what makes the most sense for Vital's continued updates to the care board.
That's a fair point. Does the healthcare advocate have anything on this topic?
Nothing from us, Chair Foster. We support the recommendation. Thank you.
Thank you. Thanks. And any public comment? Okay. Well, I'd like to thank the Vital team and Ms. Mendizabal and Ms. O'Neill for your work. If you can put up the motion language that you suggested. I'll move to approve Vital's fiscal year 24 budget as submitted to the Green Mountain Care Board, subject to the conditions presented today by the Green Mountain Care Board staff.
I'll second.
All those in favor, please say aye.
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 Aye. And motion carries unanimously. Thank you all very, very much.
Thank you.
think that's
Just
all.
gonna, we actually, so we have our presentation from Kate on the amendment, so I'm just gonna advance the slides. And Kate, you can go ahead.
Thank you very much. Hi, everyone. I am Kate O'Neill, Director of Data and Analytics for the Green Mountain Care Board, and we have one more motion for you to consider. When Vital came to you a couple weeks ago to present around their budget, they also shared information about a modification to the HIE plan in the Appendix A specifically, which are around protocols for access to protected health information. And on May 24th, we received a written letter from the Department of Vermont Health Access making that request. And I'll note that we talked about this last time, but AHS's HIE steering committee had heard about this modification request back on May 3rd, and they approved to recommend this change. The legislation that brings this to the board is that the Green Mountain Care Board does need to vote on approval of this change. Every year, the HIE plan is updated and the board makes, they vote on that. And so if there are proposed updates to the plan, they need to come before the board. So that's what we're here today to do. So if you could advance the slide, Jess. A reminder, the proposed modification is to add under Vital's responsibilities in this Appendix A of the HIE plan is to add the phrase "and subject to the approval of." So Vital, in coordination with and subject to the approval of the HIE steering committee, will participate in a data use agreement and any successor agreements with regard to the National eHealth Exchange. And the next slide is the motion, the proposed motion language. So we do support this modification. And so the suggested motion language is there for you to move to approve the amendment to add the requested language to the 2022 Vermont Health Information Exchange Plan as described in DVHA's letter dated May 24th. Which is posted on the website in the board meeting information, as well as I believe on their website probably as well.
Thank you very much, Ms. O'Neill. Any board member question or comment on the amendment? Okay. Any HCA or public comment?
Nothing from us. Thank you.
In the public? I'll let someone else move. I'm out of motions today.
I'll go ahead and move to approve the amendment to add the requested language to the 2022 Vermont Health Information Exchange Plan as described in DVHA's May 24th, 2023 modification request letter.
I'll second it.
All those in favor, please say aye.
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 Aye. And the motion carries unanimously. Thank you very much, Kate. And I think that's all we have on the agenda today. Is there any old business to come before the board? Any new business? And is there a motion to adjourn?
So moved.
Second.
All those in favor, please say aye.
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 Aye. The motion carries and the meeting is adjourned. Everyone have a nice afternoon. Thank you.